Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. As physicians, we prescribe many treatments and are usually meticulous about dosing. Indeed, dose titration is one of our areas of expertise. But I know that I rarely consider dose when prescribing rehabilitation treatment. The manuscript we will discuss today is Examining Rehabilitation Dose in Adults with Rheumatoid Arthritis, the association with baseline factors and change in clinical outcomes. It was recently published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. I'm excited to be joined by the manuscript's senior author, Dr. Caleb Michoud. Dr. Michoud is a professor of medicine at the University of Nebraska Medical Center. He serves as director of the Rheumatology Fellowship Research Program, and he is also director of Forward, the National Databank for Rheumatic Diseases, based in Wichita, Kansas. Since 2007, Dr. Michoud has been the principal investigator of the RAIN database, a rheumatology clinical registry composed of 5 clinics within Nebraska medicine. And he works very closely with Dr. Ted Michaels on the Veterans Affairs Rheumatoid Arthritis Registry, or VARA registry. Dr. Michoud has also been a very active volunteer in the American College of Rheumatology and the Association for Rheumatology Health Professionals, including roles supporting the RISE registry. Welcome to the show, Caleb.
Thank you very much for having me today, Vicky.
So I wanted to begin by getting some background because I started practicing medicine last millennium. And since that time, there's been considerable advances in targeted therapy for rheumatoid arthritis. I remember caring for patients with long-standing RA who had debilitating erosive disease. And now with early intervention, effective biologic and small molecule therapeutics, we're no longer seeing that level of disease or disability, and remission is really achievable. However, even with slowing inflammation and joint damage, we really still need rehabilitation therapies to support our patients and improve their functional limitations. Most of our clinician listeners are familiar with ordering rehab for our patients, and we very commonly will get a note back from the therapist advising us that they've done their initial clinical evaluation and asking us to approve their therapy plan. And I'm embarrassed to say, I don't really think too much about signing off on those. And so tell us the background to this study. What was the knowledge gap you were trying to assess? And what should prescribing clinicians really be thinking about when dosing rehab?
I think what we're trying to address is exactly your concern as a physician, because so often these days it's all about what DMARD and what's the prescription plan as opposed to the overall treatment plan that is sometimes hasn't been spoken to as much the last few decades, I should say, in rheumatology. And there's still a very important place for rehabilitation, physical therapy, occupational therapy, and what have you. And I think that was the goal here with this study, was to take a look at when it was introduced, how effective was it in this RA population? Looking sort of agnostic, because our study goes beyond just a specific reason for rehabilitation at a time. It's for any reason and any therapy they might be collecting along the way.
Yeah, and we're going to delve into the results very shortly. First of all, can you fill us in? You conducted this study using a prospective cohort analysis from Forward. As I said, that's the National Databank for Rheumatic Diseases. Our listeners are actually familiar with this databank because we discussed it in the prior episode with Patty Katz entitled Sleep on It. Tell us a little bit about your involvement with the Forward databank. And if you're willing, can you tell us about your Kansas connection?
So Forward is a longitudinal observational data bank. It was started in 1998 by Dr. Fred Wolf in Wichita, Kansas. And my connection there is I grew up in Kansas since 1975. I lived there. And I was actually a patient diagnosed with JRA in the 70s by Dr. Fred Wolf. And I stayed in touch with him and got my first out of non-food service job with him in the 90s. And as I worked on my PhD in physics, I took a break and continued to work with him in Forward Data Bank. So that's my connection to Kansas and Dr. Fred Wolf and the data bank. And the nice thing about this data source is, and his intention in creating it in the 90s was, there's all of these new therapeutics coming down the pipe, and he wanted to get a much larger population contributing to patient-reported outcomes and safety to get an idea of how effective are they and what are the safety concerns and what's actually happening to people over time. And that's only something you get from a much larger study. And that's what the Forward, it's now called the Forward Data Bank or the National Data Bank for Mac Diseases, attempts to do by collecting data from patients directly every 6 months. And these are very comprehensive questionnaires that ask about quite a bit of everything that you can think of that you can get from the patient directly.
Amazing. I had never understood that connection that you had with Dr. Wolf, but that's an incredible story. And thank you so much for sharing. So fill us in a little bit more on how the data was collected for this particular study. I think of Forward as a little bit of direct to consumer real-time data collection. How did you specifically identify the cohort you wanted to study and elicit rehabilitation data on?
I'm glad you think of it that way because that's what it was intended to be. So we ask about everything that the patient went through during a 6-month period on these 6-month questionnaires. And that includes how often they saw a physical therapist or an occupational therapist. It includes how often they saw a rheumatologist or a nurse counselor or, what have you. And so this is the data set that we were starting from. Of course, there's a tremendous amount of patient-reported outcomes collected as well. And we were interested in looking at what impact did rehabilitation have on those who had a history within Forward without it, then had it, and taking a look at sort of the baseline measures when it comes to physical function, pain, and fatigue the 6 months later. And because the questionnaire is at every 6 months, it's agnostic to the event that may have, triggered the reason for the prescriptions to seeing a rehabilitation expert. So we don't actually get people filling out the questionnaires at the time that they start that you might expect in a smaller, more focused study. But the beauty of collecting so much information at the 6-month period is that you can actually do studies like this, where you can start with 20,000 RA patients and then narrow it down to having how many of those had rehab at some point and how many of those with rehab had 12 months without any beforehand. So we had sort of a clear sort of screening period beforehand.
I'm going to ask the flip side of that question. How do you collect data on the clinical and functional outcomes? So, for example, if as a physician, you have a patient who is enrolled in Forward, do you as a physician also fill out questionnaires or data collection?
So we, in Forward, there's very few rheumatologists who contribute their clinical data directly because in order for Forward to be successful, we work directly with the patients. Now, most of the patients participating in Forward come from rheumatology clinics, and some rheumatology clinics collect every visit data that goes into Forward, and we help them out with getting that data back to their EMR and so they can do research on their own. But for the most part, and this study only took data from the 6-month questionnaire that the patients filled out, nothing from the rheumatologist directly.
And the patients in this particular study self-reported the rehab dose. Is that correct? So I guess firstly, tell us, how did you measure that? And do you feel that that perhaps skewed the data in some way?
Well, the nice thing is the patients report this after the fact. Like, what did you do during this 6-month period? So rarely do they report something that didn't happen. If anything, they're more likely to report, they might forget, so you do have an issue when it comes to remembering. As I get older, I see this more and more often being a bigger issue. But, when they report this, they also report what is their level of fatigue, what is their pain, and they fill out many different standardized forms of physical function self-assessment. For this study, we used the HAQ, the Health Assessment Questionnaire.
And tell us what you found then. How did you see rehab dose in association with clinical and functional outcomes for the patients?
Well, we had about 1,300 or so patients that met the 1 year no rehab and then 6-month rehab being reported. And as we expected, those with worse physical function did have greater amounts of rehab dose. And this dose really came down to how many times did you see a PTOT specialist during that 6-month period. And we use sort of the response as a minimal clinically important difference in pain and fatigue. And this is quite a large jump, improvement or worsening of about 2 points on a 10-point scale. And on the HAQ, the Health Assessment Questionnaire, it's about 0.22 on a 0 to 3 scale. And what we saw was overall, there was improvement in all categories with the highest levels of dose from the raw data. And once we took into account many other baseline factors, including demographics, social demographics, we found that the greater rehabilitation dose, the greater the improvement in physical function. And that was the one area that showed up the strongest as far as statistically significant improvement.
And so what does this mean for our patients? Should we, as clinicians, be writing the orders for rehab? And how should we use this data to better titrate treatments for our patients' needs?
I think the main message coming from this study is that don't forget this form of treatment. There is certainly a place and a need for physical therapy in your RA patients. And as a patient myself, who's actually recently been going in for PT, I've been surprised and reminded because as a child in the 70s, that was pretty much my main form of treatment. You could only do so much with aspirin and NSAIDs back then. But as someone who's been on DMARDs for many years now, I've sort of also become hey, this is what it means like to get treatment. But this shows that there actually is improvement when there's a proper amount of visits. And this is looking at about at least 8 visits in the 6-month period at some of the higher dose levels.
Yeah, I think really important to remember we're treating the whole person, right? Not just at a molecular level. And I think your paper really brings that out. Would you mind talking us through some of the limitations of this study? One that kind of struck me is very much self-reported data and to some extent exercise is a bit like medicine, right? It only really works if you take it every day. And so while you measure the number of sessions with the therapist, should we also in some way be considering the between session exercises that the patient's doing on their own, and how does that impact the outcome?
Oh, most certainly. And I think as my personal experience is showing, the physical therapist said, okay, now do this every day, this many times. And oh man, at the end of the day, I'm like, oh, I got to quickly do this in bed, which is clearly not the ideal place to be doing some of these things. So it actually goes to speak why treatment, the DMARD treatment has sort of become the default, because we have adherence issues to that as well. We definitely have adherence issues to the therapy needed. And that's why having the in-person sessions and having those recorded are so important, because they do make a big difference because it's actually happening. The treatment is actually happening. And I think we didn't measure that. So we don't know how well they were adhering to that in between visits. And, this observational data bank wasn't intended to capture sort of the effectiveness of the treatment. So it wasn't like we got the moment before they started the physical therapy baseline measures, and then after so many visits, baseline measures. The therapist would actually be doing that. Hopefully they're sort of looking at what's the overall goal, where are you at, what are the progress, if at all, along the way, and working with the patient on achieving that. You're much more likely to do that at the individual level. And that's definitely a limitation of our study.
And as we wrap up, I guess your study also only looked at RA patients. Other studies have obviously shown pretty significant correlations between rehab doses and outcomes in other forms of arthritis, in particular osteoarthritis. I think had an optimal dose of rehab much higher, somewhere around 24 rehab visits. So do you think we need to kind of revisit dosing in RA, and perhaps the dosing should be even higher?
Yeah, that is a great question. Yes. Most of the literature has been on OA patients. And I think OA is sort of it affects so many more people. And there are very few effective medications when it comes to that. And so rehabilitation has been sort of the primary form here. And it definitely showed effectiveness at much higher doses. And I think it sort of comes back to knowing that this is available, knowing that it is effective at higher doses, that our higher dose definition is at 8 or higher, it clearly shows that it could be a lot higher. And we didn't actually capture how many people actually went to 24, another limitation here. And I think it also shows the need for future studies on this, is that, if you have an area that isn't, most of your joints, the swelling has gone down, your disease activity seems to be going down, but you still have pain and physical function limitations in certain areas. physical therapy definitely needs to be an option on the table to be considered.
And so I'm going to use a cheesy pun. Moving forward from forward, we need some more enthusiastic rehab researchers to use this data, it sounds like, to inform future studies on dosing rehab for RA.
That's exactly right. And I think the first author, Louise Thoma, that was her intention. She wanted to take a look at data sources that were out there, see what she could learn in her area, and then have that as preliminary data for some future targeted studies in the RA populations. So exactly right.
Yeah, so information desperately needed by the clinicians. Let me reinforce. So, Caleb, I wanted to take a few minutes now, if you're willing, to talk a little bit about your life outside of work, because you, like a 1950s comic book superhero, lead an amazing double life. You are an accomplished researcher, a professor, a scientist, but you also run Spielbound, a board game cafe and library. Tell us about Spielbound. What is it? How did you set it up, and why?
Well, thank you. I have a big smile because don't feel like it's a double life, but you're exactly right. Every morning I'm there to check in, to get my coffee for the day, and to see how things were going at Spielbound before starting my day when it comes to the university. That came as a passion project. I often call it a sanity sparing project. If you look at some of the papers recently showing people who do well in their careers tend to have hobbies. So it started out as a hobby, playing board games. And my collection grew a little too quick. And my fiance, my future wife at the time, said, your monthly board games that have over 50 people at our house probably needs to find a different place for that if we were supposed to live together someday. So that turned into the need for building a board game cafe, a place where my games could be and a place where others could go and sort of get away from it all. There are no screens. It's all physical, three-dimensional board games that people can come in and play. And we have over 3,500 board games to play. It's the largest playable game library in the US.
So I'm going to kind of ask a little bit about this sanity-saving concept. I think I've heard other people refer to them as ghost jobs. How has the magic of board games informed your career?
As I've learned about myself along the way, my mind is constantly moving. And I love a challenging strategic board game, whether it's cooperative with people or against them, competitive with them. And I think that's been a nice way to sort of, the fact that my relaxation is also brain burning gives you an idea of who I am, gives me actually a nice break from, and I can return to the research that I'm doing as my day job. I also love that, there are games on every topic, including medicine. And a lot of people about whether it's about running a hospital, running a clinic, to about the biology, about the medicine itself that they've made into board games. So, and I also have learned that people appreciate and enjoy it all around the world. And when I go to different continents and countries, I always check out the local board game cafe, local board game stores, see what they're playing, see what they're enjoying, because it's a fantastic way to bring people together.
I'm imagining now a special interest group at the next ACR Convergence meeting. I'll ask this question because I don't know the answer. Is there a rheumatology-themed board game already for our community, or are you thinking about making one? I guess I'm imagining, the chance cards now. While completing a prior authorization, you get sent for peer-to-peer, go back 2 spaces and miss 1 turn.
I love it. There is not one that I know of, but I think it's long overdue.
So, me too. Now that you're describing this, I feel that you're the perfect person to put one together for us.
I think we'll have to work on one, and maybe next year we can talk about that.
That would be fabulous. So I'm going to take you back to something you mentioned earlier in our discussion. Your science background originally was in physics and astronomy, not pharmacology, not healthcare outcomes. What made you change direction and pivot into the rheumatology field?
You're exactly right. It was astrophysics, my undergrad, and my PhD was in physics. And that was my intention to make my career to study astrobiology, which is why I was in California. But it was my rheumatoid arthritis actually that led me to change fields, because I, in 99 and 2000, had both of my wrists replaced. And it was so traumatic, I should say, and dramatic at the time. It really impacted my ability to do research in the lab. And the understanding of others around me was such that they didn't understand why I wasn't back to work 3 weeks later, like the person with the ACL tear. And it led to me taking a break from graduate school. And Dr. Fred Wolf said he had a position open for a statistician. And I said I took a leave of absence and joined him in Wichita with the NDB at the time, or what would become Forward. And I presented and did some work at the ACR meeting in 2001. And I loved it. And I had a fantastic time and said, hey, this is for me. And I went back and I changed my career, and I haven't looked back ever since.
And so, Caleb, you've also starred in 2 documentaries. Tell us about that. And when will you be making one about rheumatology?
You have a lot of information on me. Good thing.
I like to research. What can I say?
Well, I did one in the late 90s. I don't know if I was a star. I was in an archaeological dig in the Galilee that Anne Bancroft narrated. That was my first one in the college project when I was trying to learn about ancient times in the Roman Empire. And then the more recent one, the one you can actually watch on Amazon or other streaming services, it's called Rabbit Fever, is all about kids who are in the rabbit hobby in the US who show rabbits. And I did that when I was a kid. And I was the American Rabbit Breeders Association Rabbit King winner at one time. And they had me as an interviewee. So that was a lot of fun to be a part of that. And I'm waiting for the rheumatology one. So
That's another potential passion project for you, maybe.
I actually don't think I'm in a board game one. I've been on board game podcasts a few times, but that's definitely not as common.
So multiple opportunities, which brings me to my next question for you, and one that I ask of many of our interviewees. You obviously have this kind of very eclectic portfolio of things that you enjoy doing. How do you decide what to do and what to take up and what to give up?
That is a daily struggle. But I think now that I have a family of my own, a lot easier, honestly. And I think with the pandemic as well, it sort of realigned priorities of what is important to get done. And my research will always be number one as far as important things to work on and contribute to as a patient and researcher, and knowing that it does make a difference and working with trainees. But now that I have children, sort of working with them along the way, that's been the major focus. And I see the improvement that they have as becoming human beings. They already are, but becoming older ones through playing board games. And so I'll continue that with them. A very different style, and much more likely to have a table flip with one of them along the way.
So I'd love to know how you handle that question that every kid always pops up right as you sit down to start working on something. I'm bored. There's nothing to do.
We haven't heard that so much. And when I was a kid, I was forced to run around the house several times. And so I learned never say that again. And I think that's actually why I became as active as I was as a child. I joined 4-H as a 7-year-old, and I don't think I ever looked back. I was constantly doing extracurricular from that age on. There was always something to learn and always something to do. And I still feel that way. And I actually like it when my kids might feel that they're bored, because I kind of let them go, okay, what are you going to do about it? What are you going to do during this time, as opposed to having an activity already prescribed for them. So it's good to mix it up. And it's always good to have something available that they could work on or think about, or just sort of be bored and sit with that for a bit.
And if they get too bored, you send them out with a board game, I'm sure.
There we go. Run around the house, and then you'll be tired and we can play a board game.
And so, but how about you? How do you decide what not to do?
I don't review as much as I'd like to. I don't write as much as I'd like to and research, just because there's that human limit and that sanity limit of I have to get a good night's sleep. Otherwise, I know my disease will flare. Sort of set limits there as well. And I think learning that working with others, because it's not an individual process, it's a marathon as a team marathon, not an individual marathon. also is motivational. If I know other people are counting on me, I'm more likely to get it done. But I also know it's more likely to get done when I'm working with other people.
Good advice. And I wondered if you wouldn't mind if you could share a little bit about your volunteer roles with the ACR and ARP. How did you get started as a volunteer? Why do you continue to volunteer? And do you have any advice for our listeners who might be interested in giving back with a gift of their time and talent?
I first volunteered without realizing I was volunteering back in 2003, 2004. And it was all out of a research interest to develop some new classifications for RA disease activity. And I thought this was a very important question, and Dr. Fred Wolf thought so too. And so we became active with the ACR on that. And I was sort of opened up to a whole new world of, oh, you can do a lot more than just this. And when I joined the University of Nebraska team in 2007, Dr. Jim Odell, our chief here, was a very active volunteer, and he expected everyone to be doing something. And I'm so glad he insisted it that way. So Dr. Fred Wolf made sure that I was constantly reviewing and said, for every paper that you co-author, you should be reviewing at least that many papers as a nice metric.
Yeah, good advice.
Yeah, and Dr. Odell said, hey, if you want to be part of this community, you should be volunteering at ACR. And I said, that makes perfect sense. And I was, from that point on, always at least 1 to 4 committees, depending on the roles, how much they overlapped. And then along the way, I learned that I was an ARP member, and I've been much more active in the Association of Rheumatology Professionals, knowing that I'm not a rheumatologist, but there's still a very important role for those of us who are part of that health professional team, either researchers or in the clinic support role, or even as a patient who wants to be active and contributing.
Yeah, fabulous advice. And I feel like so many opportunities for all of our listeners to contribute to the field of rheumatology. Caleb, it's been an absolute pleasure to host you on the show today. And I hope to one day get to visit your unique store with my kids and maybe pick up that new rheumatology board game.
I would love to have you, Vicki, and your family over. And I tell you, we've been testing out all of the kids in the children's section, so I can give you lots of advice which ones to try.
Oh, fabulous. My thank you today also goes out to those rheumatologists who invest time and mentorship in nurturing the careers of undifferentiated scientists. Through energy and enthusiasm, these mentors sometimes inspire exceptional scientists to switch careers from physics to rheumatology, and we're very thankful for that. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media, email us at podcast@rheumatology.org, and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.